Hey, Doc Moliver here. So, saline versus silicone with a breast lift. Here's the way I like to explain it to patients. First of all, when you do a breast lift, you're going to have a vertical scar down the breast, virtually always. Sometimes there's going to be another scar along the inframammary fold. That's a lot of tissue that's been elevated and everything's been lifted and then it's been closed up around the breast. It has a lot of stress on it. It has a lot of weight of the implants potentially on it. That might be why we'll use an internal mesh. But beyond that, saline versus silicone. Well, if you have a very thin tissue cover, you don't want to use saline because those implants tend to ripple a bit more and they look very implantish. In those circumstances, I'll use a gel implant. In this circumstance, where I've got a fair amount of breast tissue over it, there's no reason to use the silicone implant, particularly if now most implant companies are saying MRI 3 years after you put the implants in and 2 years after that, or every 2 years. So that's a lot of burden to take care of. If you're never going to feel them anyway, I'd rather use saline. But the other reason to use saline with a breast lift is what we do is we put a fill tube in here and we leave it coming out of a little tiny poke hole for about 5 days. And we fill up the implant about half what our final volume goal is. And then about 5 days later, swelling's gone down a little bit. We know the nipple's okay. We know the skin flaps are okay. Then we fill it up and then we can make it much more bespoke. The patient comes in, she's looking in the full-length mirror with our nurse of many years' experience, and then we start filling up to the final volume, and both the patient and the nurse, and if need be the doctor, can all look at what's going on and saying, how much is enough? Do we want to put more? Do we want to put a little bit less? And the patient's involved with those decision-making choices. And we find that that's very helpful. But the other thing it does is it makes the operation much safer because we're not filling up the implant all the way. Can you imagine if the implant's filled up all the way, or it's a gel implant and we got the final big size? Patient comes in the day after, which is when you should see these patients, and the nipple's a little bit blue, or some of the skin's looking a little bit blue, and we're concerned about blood supply. We can easily back off the pressure on that saline implant for a few days. Things get healthy again, everything's good, we fill it up again. With that silicone implant, we've got to release sutures to try and take the pressure off that breast to make sure that that nipple is okay, or we have to go to oxygen therapy or hyperbarics. So this is a nice safety valve that's easily incorporated into the whole bespoke plan for this patient. So that's why I like doing these saline implants if we have enough tissue coverage. If we don't have enough tissue coverage, the other option is incorporating some fat transfer during the surgery to camouflage that saline implant a bit. So we have several different ways to make it more bespoke, to make the patient part of the plan, and to make it safe.